Welcome everyone to a Weber training teleclass. I am Jim Goche, your host for today's presentation. It gives me great pleasure to introduce our presenter today, who is Dr. Simon Goldenberg, consultant microbiologist and infection control doctor at Guy's and St. Thomas's Foundation Trust. He is also a reader in clinical microbiology and an honorary senior lecturer at King's College in London, England. He consults or advises at London Bridge Hospital, Moorfields Eye Hospital, and the Hospital of St. John and St. Elizabeth in London. Dr. Goldenberg's title today, as you can see, is the use of fecal microbiota transplant, or FMT, as a treatment for recurrent or refractory Clostridioides difficile infection. Dr. Goldenberg.
Hi everyone, thanks Jim for that introduction. It's my honor to talk to you today about FMT, primarily for treatment of recurrent C. diff infection. And just before we get going, I have some potentially relevant disclosures to make, as you can see on the screen. So what we're hoping to go through today is really just to understand the epidemiology and risk factors for recurrent C. diff infection, understand a bit about the human gut microbiome and its importance in colonization resistance, describe the principles of FMT and the evidence to support its use, understand when and how FMT is used in clinical practice, including risks and benefits, and finally, just some awareness of developments in the regulation of FMT and FMT-like products, including live biotherapeutic products that may be coming to the market relatively soon. So you're probably all very familiar with C. diff infection. Here are some figures for the global incidence, and it's estimated that around 50 per 100,000 cases are seen every year. And what's very clear from the figure on the right-hand side is that this is primarily a disease of older people, particularly those over the age of 65 years whom it disproportionately affects. And in fact, in that age group, the figure for incidence is 323 per 100,000 per year. And similar to the incidence, mortality is also disproportionately suffered from this age group, with over 80% of deaths occurring in those over the age of 65 years. So we know that there are many risk factors for C. diff infection, the main one being exposure to antimicrobials, and people who receive antimicrobials are between 7 and 10 more times likely to get C. diff infection than those who are not exposed. Older age, as we've described already, and that's probably due to a number of factors, including relative immunosuppression in those who are older, natural changes in the gut microbiome leading to lower diversity, comorbid conditions, and increased use of antimicrobials. Recent stays in hospital or nursing homes also increase the risk of environmental contamination and risk of C. diff infection. Immunosuppression in itself is a risk factor, and a previous history of C. diff infection. So C. diff has a recurrence rate of around 20 to 25% in some patients. Antimicrobial associated diarrhea in C. diff is very common. The more broad spectrum the antimicrobials that patients get, the higher the risk. And we traditionally think of clindamycin, cephalosporins, fluoroquinolones, and the broad spectrum antimicrobials, the broad spectrum penicillins, being those groups of antimicrobials that are highest risk for C. diff. And that's because they deplete the normal gut microbiota, increasing the risk of C. diff through reduced colonization resistance. Around 25% of people who are treated with antibiotics get antibiotic-associated diarrhea, and about 20 to 30% of antibiotic-associated diarrhea is due to C. diff infection. The rest just comes from this disturbance in the normal gut microflora. And even in this era of better antimicrobial stewardship, there is still significant evidence of poor prescribing habits. This is a recent study that was published in 2024, a meta-analysis of 36 studies that looked at antimicrobial prescribing in the outpatients for patients who needed to be treated for a respiratory tract infection. And you can see on the right-hand side that forest plot of the proportion of prescriptions that were felt to be inappropriate, ranging quite widely from about 13% in Japan up to 90% in Ecuador. Overall, the pooled prevalence of inappropriate antimicrobial prescription was 45%. So that's a staggering number. Nearly half of antimicrobials prescribed in these studies were deemed to be inappropriate. So although there's a lot of attention on good antimicrobial stewardship, there is still a significant way that we've got to go in order to reduce the risk of C. diff infection and other risks. And really the underlying issues here are a decrease in the diversity of the gut microbiome. And this is just depicted in various different on the figures on the screen right now, really just showing that patients who have recurrent C. diff infection have a decreased phylogenetic richness. So the diversity of organisms in their gut is significantly reduced, as well as the total number of organisms that are there. And these changes can persist for quite prolonged periods of time. There are some studies that looked at patients receiving antibiotic treatment for eradication of Helicobacter pylori who found changes for up to a year after treatment. So this perception of just a short course of antimicrobials won't do my gut microbiome much harm may be misguided. And I think there's still a long way, as I said just on the previous slide, that we've got to go in order to prescribe antimicrobials more intelligently. So the incidence of recurrent C. diff, if patients have an initial episode, there's a risk of them having a recurrence of between 20 and 25%, and 40 to 65% of those that have a further recurrence will go on to develop another one. So there's a subset of patients that develop multiple recurrences, that get treated with antimicrobials, that get better for a period of time, but then inevitably have a recurrence and develop symptoms again. And it's very difficult to treat that subset of patients, even with the antibiotics that we've got to treat C. diff at the moment. And according to the European guidelines, the most important problem in treating C. diff infection is the high recurrence rate. So the antibiotics that we've got to treat C. diff effectively, there's really only two: vancomycin or fidaxomicin. Metronidazole we used to use, but has been relegated somewhat in the most recent updates to the international guidelines. The problem with these antibiotics is that, of course, they themselves can have a significant impact on the normal gut microflora. So although they work very effectively against the C. diff, they don't allow restoration of the normal gut flora so that you're protected going forwards. And here's a very clear example of that on the left-hand side. This is a heat map that is being produced from whole genome sequencing of patient stool samples immediately before and after they've taken a treatment course of vancomycin. And each of the lines is a different organism, if you like, from the three different genera here. And you can see essentially where it's white, that means pretty much total wipeout of that particular organism. So Bacteroidetes, Firmicutes, completely destroyed more or less, and that's being replaced by the Proteobacteria. Proteobacteria are the exact ones that you don't want to have. These are the potentially pathogenic organisms. So vancomycin, although it's good at treating C. diff initially and killing it off, it does have a significant effect on the normal gut microbiome. Fidaxomicin isn't quite as bad. In fact, it's pretty good because it's a narrow spectrum antibiotic. It's targeted against C. difficile and some other Clostridioides groups. And so it can preserve the normal gut microflora relatively. And that's shown on the graph on the right-hand side, looking at levels of Bacteroides fragilis in the colon between treatment with fidaxomicin, and you can see they're relatively preserved. Those lines in green compared with vancomycin, where it's significantly reduced, as shown in the grey bars. So fidaxomicin is associated with a significantly reduced risk of recurrence. The reason that a lot of hospitals are slightly reluctant to prescribe it is because it's much more expensive than vancomycin. And so those are essentially our treatment options. And for a lot of patients who fail these antimicrobials, it becomes a real problem for them. And so we're forced to look into other methods of dealing with them. And one of those methods is restoration of the microbiota. And this graph is just really showing what I've already explained. Risk factors for C. difficile, reduced diversity of the gut microbiota, being exposed to the spores which are commonly encountered in the environment, toxin production leading to disease and symptoms of diarrhea, etc. The antibiotics are not really working to help restore the normal gut microbiota, so the alternative approach is microbiota restoration via FMT, and that's able to reduce the recurrence rate to around 10 or 15%. And that's the rationale. This disturbed balance of the intestinal microbiota causing disease, causing C. diff infection, which we're attempting to correct by reintroducing carefully selected and carefully screened donor feces. And there's a number of different administration routes that we can use, either by colonoscopy. So patients have their normal bowel prep, and we insert the colonoscope, and down the lumen of the colonoscope, we infuse fecal microbiota suspension. A similar way is just by administering it by enema, which is much more simple, but perhaps doesn't get around the whole of the colon. An alternative method is to go the other way, using a nasogastric or nasoduodenal tube and infusing the solution down that tube into the lower part of the stomach or even further down. And then finally, more recently, oral capsules have been introduced, and they tend to be easy to administer, none of this preparation that it's needed, and preferred by patients. So this was really the study that kick-started the modern interest in fecal microbiota transplant. This was published back in 2013 in the New England Journal of Medicine. It was the first randomized controlled trial of FMT to treat patients who had recurrent C. diff infection. 43 patients were randomized to 3 different arms. 17 of them were randomized to receive FMT via nasoduodenal tube. That included giving them a bowel lavage, which is essentially just bowel prep. 13 were assigned to receive vancomycin, the standard therapy to treat C. diff infection, and another 13 were randomized to receive the vancomycin in addition to bowel lavage. And the authors felt it was important to include bowel lavage because that in itself can affect the normal gut microbiota, so important to control for that. It was a small study. And the reason it was a small study is because there was an interim analysis that was planned midway through where the participants up until that point were unblinded, and they looked at the effect of the fecal microbiota transplant. And you can see the results on the right-hand side. So this is the percentage of patients who were cured of their C. diff infection without having a relapse after 10 weeks of follow-up. And 81% achieved that who had the FMT. Some patients who didn't improve after the first FMT were allowed to have a second FMT, and when they were included in the analysis, the percentage that were cured without relapse increased to almost 94%. Compare that with the group that just got vancomycin, which was just 31%, and the group that got vancomycin with the bowel lavage, which was 23%. There's a very clear difference in those groups, very obvious. And the ethics board decided that the difference in the groups was so extreme that they said, you should stop the study at this point. You don't need to gather any more data. End the study. Clear what the results show. No need to continue. And that's why the study was so small, essentially. So when this was published, lots of interest, as you can imagine. We'd been desperate, really, for extra treatments in helping this group of difficult patients. And when this was published, this really stimulated a whole load of research and interest in FMT. And since then, so this is really showing, giving us a clue into the mechanism of action of FMT. So this is from the same study. This has looked at gut microbiota diversity using an index called Simpson's index. And you can see the donors had a high index indicating a healthy microbiota, a healthy diverse microbiota. The patients who had recurrent C. diff infection had low diversity, but that was significantly increased to closely match the donors after receiving the FMT infusion. And so really, that's what we think the mechanism of action is, increasing the diversity such that the new healthy bacteria can provide colonization resistance against the C. difficile. And really, since then, there have been a number of other clinical trials that have been published in the literature, all showing, with the exception of maybe one or two, very similar clinical efficacy rates in the order of about 80 or 90%, depending on the route, either nasoduodenal tube, which was the original study, or via colonoscopy, via nasogastric tube, via enema, all quite similar results and supporting its use. I mentioned capsules already, slightly newer approach, but there are also a number of clinical trials looking at this too. And again, I think the efficacy is very impressive, with the exception of that last study there. The others showing clinical efficacy in excess of 90% using capsules. So very impressive. And that's really led to a number of organizations being established across the world that try and deal with the logistics. We'll come on to the logistics in a few slides, and I'll show you how we actually manufacture the capsules. But it's not easy. It's not easy to find suitable donors and do the screening and actually do the manufacturing. And it's probably not reasonable to expect individual hospitals to have the capability to do this. And so there are a number of stool banks that have sprung up over the world to try and centralize these functions and to provide FMT to hospitals and healthcare providers who wouldn't otherwise have access to this therapy for patients. And we have tried to standardize things a little bit. There are a number of international guidelines. These are ones that I've been involved in, which were a joint effort between the Healthcare Infection Society and the British Society of Gastroenterology, really looking at the evidence base to come up with some recommendations for things like how you go about selecting the donor, what things you should test for, what are the control measures that you have to put in place when you're manufacturing FMT products. And although, again, you'll see when we talk about this in a little while, there is a problem with standardization and really understanding what's in the FMT products. Hopefully guidelines like this and others that have been published will help to start standardizing things better. So how do we go about doing it? This is there's a leaflet drop that we did for people living in the local area close to the hospital that I work in central London, that we targeted to try and increase interest in becoming a stool donor. So we did a leaflet drop to thousands of people who live locally. And the reason that they need to live locally is because you want the stool donation to be fresh. Lots of the bacteria that's in stool are very strict anaerobe, and if they're exposed to the normal atmosphere, they start to die off. And so we have a restriction in donors needing to bring the donation to us within 2 hours of it being produced. We're also quite strict about it not being something that we pay people for. This is really something that we want people to volunteer for the benefit of greater good, to help other people. We pay travel expenses, but unlike in the States, we don't give payment. And we feel that that's quite important because you'll see in a second, there's lots of questions that we ask for patients, and there's no real way of us verifying those answers. So we're relying on our donors to be honest. Some of those questions are quite intrusive, asking about sexual history and injecting drug use. And when you start bringing in payment into the equation, there is potentially the possibility for some people to be economical with the truth in order for them to get the payment. And that's what we wouldn't want to do. So for that reason, we don't offer payment. We asked them a whole load of questions. These are the main ones. It's really important that they've not had any antibiotics within the past 3 months at least, but preferably in the last 12 months because of the effect that it has on the normal gut microflora. They shouldn't have any exposure to HIV or viral hepatitis, any known previous or latent TB, any other risk factors for blood-borne viruses, which would include high-risk sexual behaviors, use of illicit drugs, any tattoos, body piercings, needle stick injuries, blood transfusion or acupuncture, all within the previous 6 months. There is a bit of scope there to allow donors, particularly, if they've had a piercing in a registered place in a reputable place in a country that you'd not be worried about kind of hygiene. So there is a bit of scope for latitude there. Anyone who's received a live vaccine in the past 6 months, if they have any underlying GI conditions or symptoms like inflammatory bowel disease, irritable bowel syndrome, chronic diarrhea or constipation, celiac disease, any kind of surgery on their abdomen or bowel, including bariatric surgery, and also acute diarrhea within the 2 weeks prior to donating. Also, if they've got a family history of any significant GI condition, particularly inflammatory bowel disease or colorectal cancer, that would exclude them from being a donor. If they've got asthma or any other kind of atopic disease, any autoimmune condition, any metabolic condition, including diabetes or obesity, any neurological or psychiatric conditions, or known risk of prion disease, chronic pain syndromes, including chronic fatigue syndrome and fibromyalgia, any history of cancer. If they're taking any kind of regular medications in the last 3 months, then that would also exclude them. Growth hormone, experimental vaccines or drugs, having traveled to any tropical countries within the preceding 6 months. So those are the main questions that would mean that they would have to be excluded. If they pass all of those, then we start testing them. And we test their blood and we test their stool. And the things that we're looking for in the blood: hepatitis A, B, C, E, HIV, HTLV, syphilis, Epstein-Barr virus, cytomegalovirus, strongyloides, entamoeba. We do a full counter differential, liver function test, creatinine electrolytes, and CRP. So broad spectrum kind of health tests there. And then their stool samples are also tested, and we're looking for C. diff, Campylobacter, Salmonella, Shigella, Shiga toxin producing E. coli, any kind of multi-drug resistant bacteria like Carbapenem maize producing Enterobacterales or ESBLs, any kind of parasite that we might pick up, including Cryptosporidia and Giardia, Cyclospora and Isospora, Helicobacter pylori, norovirus, rotavirus, and of course, SARS-CoV-2. It's a bit debatable whether we still need to be testing for that, but we are at the moment. So I think you can appreciate it's quite a comprehensive, robust look at the donor, because we want them to be as healthy as possible. Not only because we wouldn't want to transmit an infection to a vulnerable patient with recurrent C. diff infection, but there's also potential risk of transmitting risk factors for non-infectious illnesses. So you saw that there was an exclusion for psychiatric and neurological conditions, and there are a whole range of different conditions that it's postulated have a link to the gut microbiota. So if anyone has one of these conditions, they do have the potential of having a disruptive gut microbiota, and so we wouldn't want them to be a donor. So once they've passed all of those screening tests and they're accepted as a donor, we give them a collection kit, which is pretty simple. Basically, this little device that you see that just fits over their toilet bowl. We ask them to produce the whole of the stool sample, and yeah, they need to bring it within 2 hours, and we need to process it in our freezers within 6 hours. So really just minimizing the amount of time that the bacteria are exposed to room air, so that we can preserve as much of them as possible. At every donation, we ask them a whole range of secondary questions just to check whether they've got any new symptoms or risk factors, including travel and new sexual partners, since first responding to the initial questionnaire. If they do, then they will get deferred and reviewed. If they don't, then we accept the donation and we start processing it. And it's not complicated. It's really quite basic steps to dilute out the sample, to filter it, to get out any food particles, and then to separate it a bit more. So basically what we're doing is just homogenizing it with some normal saline, just so that we dilute it out. And then we're filtering it, removing those kind of undigested food particles. We do a centrifugation, a two-step centrifugation, so that we can remove further food particles and concentrate the bacteria down. And then, yeah, you can see some pictures here. You might recognize that thing on the right-hand side as being a protein shaker. And that works really well with a little wire ball in to homogenize the sample. And we find that to be a simple method. And then you can see some examples of us filtering it here and adding a few excipients. So we add something called trehalose. This is a sugar, basically, that protects the bacteria from cell wall damage when we put the sample into the -80 freezer. That's quite important to do. Otherwise, the viability of the bacteria would be affected. Once that's added, we transfer the sample to Petri dishes to increase the surface area, and that goes into -80 freezer. Once it's fully frozen, it then gets lyophilized, which is essentially just a freeze drying process, a machine that's under vacuum at low temperature, -50, to draw off any water so that it dries it out and dehydrates it. And then once that's fully dehydrated, then we're left with almost like a kind of flat pancake of crispy material that gets broken up, and then we put them into capsules patients can then ingest. So there's a picture of the lyophilizer, there's a picture of the final product once it's been lyophilized on the right hand side, and once it's been kind of broken up into a powder that can be put into the capsules. This is all done by hand. It's very kind of labor intensive and takes quite a while. It's not really done on a industrial site process. We wouldn't be able to do that because each individual donation is a batch in itself. And so these are very small batches. Those are the capsules that you can see on the right hand side. We end up with 5 of those capsules that patients ingest. And yeah, this is kind of just stored in our freezers until it's ready to use. We obviously know who the donor is so that we can make a record of that in the recipient's medical record, not by name. The donor remains anonymous. Only we are able to link the donor to the recipient. But if there was a problem where we had to go back and trace the sample, we could do that. Potentially, if we needed to do any additional testing, we'd be able to do that. And yeah, the capsules are quite important. So obviously the pH of the stomach is low. And if the bacteria were exposed to this low pH, they would get damaged and the FMT probably wouldn't work. So these capsules are delayed release, which means that they dissolve at a high pH that wouldn't normally be encountered in the stomach. So they start dissolving between pH of 6.8 to 7.2, which is really the pH of the duodenum. And so they're in that way they're protected against the low pH of the stomach, and they remain intact until it's safe for them to dissolve and release the contents. So that's the way that we get around that. This is just a proprietary capsule. It's not something that we've invented or made. It's freely available. We just buy the empty capsule shells and put the FMT inside. So yeah, a bit about it's important to do this properly. It's important to be aware of the guidelines and to follow the guidelines as much as possible in terms of selecting donors and recruiting them and making sure that you test them properly, because things do go wrong. And here's an example of where something's gone wrong recently. So this is a safety alert from the Food and Drug Administration in the US. And basically what happened was there were two patients who received FMT. They were both immunocompromised. I think they were recruited to a clinical trial, but they both developed invasive infections caused by ESBL producing E. coli. Unfortunately, one of the patients died. It became apparent that the hospital that was manufacturing the FMT were not screening their donors for ESBLs, unfortunately. And so that's how it came to be transmitted. And so that was proven by obtaining some of the stored aliquot from the donors that was able to link the ESBL producing E. coli from the donor to that was causing the infection in the two patients. So this could have been avoided, and yeah, things do go wrong. It's really important for us to pay attention to guidelines, and it really just brings home the problem of FMT in that although we're screening the donors, we still don't really know what's in the products that we're manufacturing. We have a good idea about what's not in the product, so all of the pathogens that we screen out, but we don't know what is actually in there. And to be honest, although we've got a good idea, we don't know for sure what the mechanism of action of FMT is. And that is a bit of a problem because most regulatory bodies across the world consider FMT to be a drug. And the way that we typically think about drugs is that it's got a well-described and understood mechanism of action. It contains certain chemicals at known concentrations, and it's studied very well. And that is just not the case for FMT, unfortunately. So as well as there being concerns about transmission of infection, as I alluded to earlier, there are concerns about transmitting non-infectious diseases like obesity and risk for metabolic syndrome. As you can imagine, that is very uncertain and would be very difficult to study. It would require huge studies of association over many years, if not decades, to really tease out. But nevertheless, that risk is still there. Some of the other challenges with traditional FMT is this lack of standardization and characterization of the final products that I've just alluded to. Each donation is unique and highly variable, and that means that our final product is unique and highly variable. And we're not entirely sure that a product will work for a patient. Additionally, there are problems with scalability, which has led to unequal access to products across the world, really because this is donor-derived. We're reliant on individuals to donate their stool, and you can imagine, as you've seen the manufacturing process, it's really quite small scale, very difficult to scale this up in its current form. Safety concerns I've already talked about, and I've already alluded to this uncertain regulatory oversight. And this is really interesting, kind of just demonstrating this enormous variability. We think that the mechanism of action is the restoration of a normal gut microbiota by providing healthy bacteria, but that's kind of ignoring the viruses, the bacteriophages, the fungi, which might also provide significant benefit, and also completely ignores the metabolites that are produced by these organisms. Maybe they have a role to play in suppressing or counteracting C. difficile indirectly. This study shows significant variation in the gut microbiome profiling in donors. So this was a study that recruited 20 healthy women in Belgium and asked them to submit a stool sample every day for 6 weeks. And they did whole genome analysis of those stool samples. And each color is a different participant. And essentially, where the markers are on that graph is the amount of variation within that donor. And actually, the day-to-day absolute variation is substantially larger within than between individuals. So in other words, the donation that you provide on day 1 might be more different to the donation that you provide on day 7 or 8 than it is different from a different donor that was producing. So this is a problem. We like things to be standardized, particularly when we're giving them the label of a drug. But unfortunately, FMT in the traditional way that it's being produced is very difficult to standardize. I talked about scalability in unequal access as well. This was a survey that was done 5 years ago in Europe, looking at the provision of FMT for either routine or experimental indications, and C. diff specifically on the right-hand side. And you can see quite significant variation throughout the European countries in the amount of FMTs that they were doing per population, standardized per population, 100,000. So this just kind of goes to show there's unequal access to FMT, primarily because of the issues about scalability. Regulation is an issue. It's a bit of a mess, to be perfectly honest with you. Different approaches have been taken throughout the world. In the UK and in many of the European countries that you see on the left-hand side, as well as US. We've gone down the route of a drug or medicinal product regulation. In Italy, Belgium, and Australia, they have tended to use kind of a tissue and cells regulation, which to my mind is probably better suited. In Finland, it's just classed as a therapeutic intervention, and in many other countries, it's really not defined at all, and regulation is absent. Hopefully, within Europe at least, things are starting to change, and in Europe, there's the new classification called the SOHO regulations, substances of human origin, and FMT will be one of the first products to be regulated under this new category. Breast milk is also being regulated under this category as well. Hopefully, this will lead to further standardization of processes and better control, and therefore quality and safety of the products that we produce within Europe. So there is an evolution. I've talked a lot about the problems with traditional FMT. There are a couple of licensed products in the US and Canada that have come to the market, Microbiota and Faecal. Microbiota and Faecal we'll talk about in a little while. They are essentially kind of next generation traditional FMT. They still rely on donors, human donors, providing samples and then being processed in some way. So still have the issues with poor scalability and unreliable supply, as well as the problems with lack of standardization. As we look more into the future, there are perhaps some products that may come to market that don't rely on donors, that rely on identifying a consortia of different strains that are produced in the lab, that can be completely standardized and controlled and at known concentrations and quantities, and more akin to a traditional drug in the normal way that we think about it. And that obviously could deal with the issues about standardization and about scalability. So they may come to the market. In the meantime, at least in North America, Rebiota is available. This is what's termed a full spectrum microbiota based therapy. It's very similar to traditional FMT, to be honest with you. It's administered as a single enema of 150 mils, following standard of care antibiotics with a gap window period of about 2 to 3 days in order for those antibiotics to be washed out from the lumen of the gut. No bowel preparation is required, and as I say, this has a license from the FDA for prevention of recurrent C. diff infection in adults over the age of 18 years, following standard treatment for recurrent C. diff. Again, it's derived from a single donor. It's not pooled. They use a minimum of 50 grams diluted in normal saline and polyethylene glycol. They guarantee that it contains at least 10 to the 7 organisms, but it's quite expensive, certainly by European standards, $9,000 US. Yeah, I'm not sure how well this would do in the UK or Europe or any other markets for that matter, and I'm not really clear whether the intention of the manufacturer is to expand into other territories, but for the moment this is only available in the US. It's stored frozen at -80. You thaw it at room temperature for an hour before the patient arrives, and could be administered on an outpatient basis from anyone who's familiar with giving an enema. Basically, it's pretty simple. Here are the results from the trial. On the left-hand side, showing patients who responded to the treatment without recurrence, 70.6% for those receiving Rebiota, compared with 57.5% receiving the placebo. And so over 92% of patients had treatment success at 8 weeks and remained free of C. diff infection recurrence for 6 months. So pretty good results, yeah, perhaps a little bit more standardized than traditional FMT, and comes with the benefit of having an FDA license. The other product that's available is a little bit different. It's potentially a little bit more advanced. These are capsules, and they are treated in a way such that the stool donation is treated with ethanol. And most of the live bacteria are killed with that ethanol. Only the spore-producing strains remain. So this is not a full spectrum product. It is a fractionated product. And the dosage is 4 capsules taken on an empty stomach once a day for 3 consecutive days. It can be stored at room temperature or in the fridge. Has a relatively long shelf life of 3 years. And again, it needs pre-treatment with antibiotics and a gap of 2 to 4 days for those to be completely flushed out of the system. This needs a bit of a gentle bowel prep. 296 mils of magnesium citrate on the day before and at least 8 hours before taking the first dose. This is quite gentle. I think this is about 20% of the normal dose of a bowel prep that you would get if you were having a colonoscopy. So nowhere near as bad as that. Again, the FDA indications are very similar. either the second recurrence, meaning the third episode following standard treatment with antibiotics, or the first recurrence, meaning the second episode in patients who have a high risk of recurrence. That's defined as any of being over at the age of 65, if you're using proton pump inhibitors, if you likely need antimicrobials in the future to treat something other than C. diff, if you live in a skilled nursing facility or a hospital inpatient, or if you've got a severe underlying illness. This one's even more expensive, 17,000 US dollars. That feels like way outside of the realm at which, certainly in the UK, we would consider to be cost effective. So it was brought to Europe or the UK. They will need to significantly reduce the cost. Again, these are the results from their phase 3 randomized controlled trial on the right-hand side, showing the capsules SARE 109. 12% of patients suffered a recurrence, compared with 40% of patients receiving the placebo having a recurrence. So, yeah, decent results there, decent evidence, but very optimistic pricing. There are lots of other candidates in the pipeline, lots of companies that are involved here trying to come up with solutions, either in terms of single strains or in terms of consortia of different strains of bacteria that are combined into a single product at various different phases, either kind of preclinical through all of the different phases of discovery and development. So it's a very competitive market. Lots of people interested in this. Hopefully we will see more products come to market for a variety of different indications. Here is probably the leading candidate, and this is what we can truly define as a live biotherapeutic product. So this is VE303. It is currently in phase 3 randomized controlled trials across the world. It consists of 8 different strains of Clostridiales that were originally isolated from a healthy donor. You can see the different strains on the screen, and doesn't involve a donor anymore. It's not donor derived. It's manufactured from clonal cell banks, so you can be assured of the consistency, and there shouldn't be an issue with scalability and supply of this. So if this works and the phase 1 and phase 2 trials look promising, this could be a bit of a game changer in how we approach restoration of the gut microbiota in patients who need to be treated for recurrent C. diff infection. And that's just a summary of the previous few slides. Rebiota and VOWST, relying on human stool donations, relying on us screening the donors to exclude pathogens, basic processing, versus these live biotherapeutic products that remove the need for a donor and allow us to scale up. So really, just to summarize, C. diff causes quite significant morbidity and mortality across the globe and has quite a high rate of recurrence. This is driven by changes in gut microbiota, decreased diversity. Fecal microbiota transplant is a way of restoring normal structure and function of microbiota, but traditional FMT relies on human volunteers who've been rigorously screened. For that reason, there are problems with standardization, characterization, scalability, and regulation. However, there are now FDA-approved microbiota-based products for prevention of recurrent C. diff, and that's significantly changed the treatment landscape. But looking to the future, we might have the availability of non-donor derived live biotherapeutic products to treat a range of different indications. That's everything I had. Thank you very much for listening.
Thank you, Dr. Goldenberg. That was a fascinating presentation for this microbiology tech sitting here, I have to admit. And I'm also East Coast time of North America before breakfast, but this doesn't put me off at all, which is a bit concerning. Do you know, I was the president of our national organization back in 2012, and in 2011 they gave me free rein to talk about a 2020 view of 2020. which is 5 years ago now. But in that, I had been semi-joking around about banking my own feces if I had a procedure coming up. So if I was a healthy adult facing something like, say, knee replacement surgery, meeting most of the criteria, being a fecal microbiota transplant donor, do you know if we've looked at letting patients bank their own feces and go through the procedure that you described in case when I receive my prophylactic antibiotics, a little bit of a cephalosporin before the knee replacement surgery, if I came down with C. difficile, I could get my own stool back?
Yeah, it's a really interesting concept, autologous banking of stool, and it has been looked at in the context of a couple of clinical trials. The one that springs to mind is patients who are undergoing treatment for cancer. Obviously, they get lots of antibiotics and chemotherapy that can affect their gut microbiota, so it seems very sensible in that context. In routine practice, it hasn't been adopted. I'm not quite sure why that is. Maybe to do with logistics, but of course it gets around all of the safety issues that we're concerned about. So I am slightly surprised that it hasn't been more widely adopted, to be honest with you, because to my mind it makes complete sense.
So I could start up in my retirement, my gym safe stool business here. So a second question, with your donor screening, could you give us a rough idea, if you had 100 donors come, how many actually meet the criteria of those 16 or 17 criteria that you listed?
Yeah, it depends at what stage you weed them out, to be honest. We do get a lot of inquiries from people who are expecting payment, to be honest, and are doing it for financial gain. So they obviously get weeded out straight away. So if you included those, I'd say maybe only kind of 10% get through all of the questionnaire screening and the testing. A lot of people are excluded for a variety of different reasons.
And I know here in Kingston, Ontario, where I sit, down at Queen's University and Kingston General Hospital, I have seen those donation signs up where they're asking, it's a university, so they're looking for young, healthy adults that live on campus that could possibly be donors. So I know that is moving forward. I'm very excited, though, about the clonal strains that you're actually looking at, because it gets rid of all of that problem. We can just sort of mass produce them. A quick comment perhaps on the use of probiotics when you are assigned antibiotics. Is there any benefit to that, or does it really depend on the probiotic combination?
Yeah, you kind of touched on a good point there. I think in common with FMT, the type and breadth and quality of probiotics that are available are so variable that it's quite difficult to draw conclusions from the evidence base. I think it's really quite mixed. I think the studies that I've looked at have been somewhat disappointing in treating C. diff infection. I think the evidence for preventing C. diff infection is slightly better, but I suspect it depends quite heavily on what is contained within the probiotic. So I think a lot of the patients that come to me that have recurrent C. diff infection have tried probiotics before, and they haven't been successful, unfortunately. And I think that is probably related to the diversity. You might have kind of 5 or 6 strains in a probiotic versus the hundreds, if not thousands, that you're administering via FMT.
And that's always been my concern when I look at some of these over-the-counter type medication, where you look at the ingredients, and I'm thinking, you've only got 2 or 3 strains of lactobacilli in here, and knowing the diversity, I've always questioned that. So again, thank you very much for this presentation. There's a lot for people to take in here. There's a lot we still don't know about the normal microbiota, that is for sure. So it's going to be very interesting to see where we go. On my next slide here, I do want to bring to everyone's attention that November 19th, a week Wednesday, where I'm sitting right now, is World Toilet Day. There's a good URL here where you can go and look as to what happens on World Toilet Day. It's not as funny as it sounds. There's not a lot of the global population that is actually able to defecate in a hygienic toilet. And what happens with our waste when it gets out into the environment is a huge concern too. So that is coming up. I do encourage everyone to take a look at this and remember World Toilet Day on the 19th of November. If I can advance to the next slide. I'd like to thank our patron members that sort of flipped past there. Diversity, a subsidiary of Solenis, Virox Technologies, and Gamma Healthcare. I'd like to thank them for being patron sponsors. We do have a calendar of upcoming presentations here, I think. We do. We've had to cancel one, as you can see, on the 13th. We do have a special lecture in the works for World Toilet Day, and we have some presentations coming up in December. So thank you again for listening, and thank you, Dr. Goldenberg, for this fascinating presentation.